Okay.
Hi, good evening, everyone.
Wait. Not yet. I'll cue you in.
Oh, I see.
Okay.
It's already
Sorry.
time, you say.
No, not yet. This time. And okay. In 3, 2, 1.
Hi, good evening, everyone. Okay. Hi, good evening, everyone. Welcome back to our last session of our webinar for this year. Of course, we restart again next year, mid of January, after I come back from Nepal. I'll be in Nepal for about 2 weeks. And we have here again one of my favorite, Dr. Manchin, doing spot diagnosis in radiology. And I always have fun. So this is again an interactive session. I would hope for you to participate and take a good guess of what the X-ray or the radiology imaging show. And it's funny, we can't actually stream live to Facebook today. Something is wrong. So I will let Manchin go ahead and then I will inform the Facebook people to come in through Zoom. Okay, Manchin, go ahead.
Okay. Hi, everyone. Good evening. I'm Manchin. Can everyone see my screen clearly?
Yes,
Can see the whole screen is the X-ray, right?
yeah.
So today I will show just a few chest X-ray and then more are MSK today, and also going to some CT and MRI brains if we can catch up with our times today. We have only 1 hour, right?
Yes.
So since last time we have a very interesting interactive session during the last meeting, I hope today our participants are more active in answering the questions and also giving their diagnosis or differential diagnosis of the films so that we can learn together. Okay? But I can't see their chat though.
No,
And they
yes,
can answer to the chat, right? They can
yeah,
answer to
that's
the
right. The chat is there.
Okay. Come, so this is the first X-ray. This patient is a real patient, recent, came to our hospital, presented with a neck swelling. Okay, so then we did an ultrasound, found out a lot of lymph nodes, and this is the chest X-ray. So can anyone look at the X-ray and give me some differential diagnosis or your findings?
Okay. Come, just key in.
Key in the group chat.
Yeah. As usual, I think Gopi is here. Gopi. Every week I call Gopi out. Come on. Anyone?
This is an easy one actually. Nobody?
Can Okay, anyone? Okay, she already said lymphoma, right? Did you say lymphoma?
I didn't. I just say multiple lymph nodes.
Oh, I see. Sorry. Multiple lymph nodes. So think, okay, please type in the answer. Let me think. Okay, they are slow starters. Sometimes.
So let us describe the X-ray here. So this X-ray we can see is a PA erect chest X-ray. So from this one we can see there are actually multiple lung nodules here, and then occupying in all 3 zones bilaterally. Then the largest is at this right lower zone here. Okay, so this X-ray showed multiple lung nodules. Differential will be metastasis or can be primary lung tumor with other metastasis. Okay, so TB is less likely in this case because the lung nodule is quite big, look like cannonball lesion. This a few things.
I
Okay.
see.
Cannonball will be larger actually, so this one I can only say multiple lung nodules. All right.
I was looking at the mediastinum only because you say lymph nodes. So I was
Yeah,
thinking,
here also, I think here also. Here also bulky. Can you see this? Mediastinum. So this also a lymph node is already confirmed by a PET CT. This part also a lymph node. So you can see the bulkiness here. Normally, we don't see this bulkiness. We just see a very nice aortic outline going smoothly, followed by the left atrial appendages. Okay, so we're going to the next X-ray. What about this? Oh, today we have slow response.
wait, you just showed only. Okay, this one. Anyone? Come on. Yeah, the last one we had also, it took about 3 or 4
Then only the start.
years. Okay, anyone? The chest look elongated. I'm
Any
looking
findings?
granuloma.
On the left, yeah, you're right. But normally we don't use the word granuloma immediately in our description. You use a nodule first. Okay, actually this X-ray I've shown during the last session. If you can
Oh,
remember, it's the last X-ray that I showed.
oh, I cannot remember.
So you can remember. Okay,
Eh,
there's a nodule here.
So how would you describe the nodule for?
I can only say there's a nodule at left lower zone, and
Uh-huh.
then this less so they have to further investigate.
Okay.
But it does look quite benign because well defined, but hard to say just based on one single
So the
X-ray.
well-defined should be in your description also lah.
Yes.
Okay.
Okay, so next going to this patient went for a CT scan. So you can see actually the nodules is arising from the breast. It's a breast calcification. So it can mimic a lung nodule on chest X-ray. Okay? Mm. So what about this? Easy one. Abdomen X-ray. Anyone can give me some answer? Bowel obstruction. Emily, yes. Which bowel, large or small bowel?
Okay, anyone else other than Emily?
Gopi is answering now. Hi.
Okay, Gopi, I love you, Gopi. Small.
Yes,
Emily says
yes.
small.
Correct, it's small bowel obstruction because of all these this is standing X-ray, so you can see multiple air fluid level and then the valvular conniventis. Okay, across the bowel lobe. So this is small bowel obstruction. Next step will be CT scan to look for point of obstruction. Okay. Next. What about this? This is CT abdomen.
Oh, this one difficult. I cannot. Anyone? Okay, maybe give us some orientation of where
Okay.
about everything is.
So this CT axial view, so meaning it's a transverse section. Then from here, normally when we show CT abdomen, there's something in the bowel lobes, okay?
Okay.
So you
So
see if there's any abnormal thickening or any abnormal bowel lesion or nodal lesion that you can see.
I can't. Sorry.
Can anyone answer?
Anyone? Anyone with radiology background? No one?
No one.
Okay.
Difficult. This is not difficult.
Okay.
Yes, Ong Chuan Ming, correct.
Interception?
Yes, there's intersubsection here. Very good. Because you can see a telescoping of one of the bowel lobe, and then inside this
I
ascending
see.
colon. Yeah. So what caused the intersubsection?
What
So
caused
this,
interception?
yeah. because
It's a child, is it?
in pediatric is common, there's no cause, but in adult, normally there will be a cause. There will be a mechanical cause
I see.
that
So
occurs
it's
in adult. So this one
tumor.
actually is a ascending tube. No, it's not lymph node. This one is a ascending ascending colon tumor, sorry.
How do you see where the
This whole
intersection?
thing is the circumferential thickening of the ascending colon, while this lobe inside is the cecum.
Oh, I see.
Okay, so I will show you, this is a
It's not
coronal view.
difficult.
Then you can see the bowel lobe like telescoping inside this mass here. Can you see?
Okay.
So good, Emily can see the tumor. This ascending colon tumor is already proved by colonoscopy. They saw the tumor itself.
So when you have intussusception, when you do a colonoscopy,
They can't
But-
pass through,
can pass through.
cannot pass through. They can only see. This one
Oh, cannot pass
interesting on
through,
the CT
right?
findings.
Okay.
Okay, this is an interesting case. So this is a huge tumor mass. All right, you can see the rest of the bowel lobe. These are filled with contrast, and then the wall is very thin and smooth, but this one is significantly thickened. All right.
Okay.
Okay, come. So this is the coronal view for the same case. Okay, what about this? CT PNS in bone window. So when we show this, we are asking you to look at the paranasal sinus.
Oh, this one need radiology background.
Yeah, but you can tell me whichever, any asymmetry or any,
Left sinus. Okay, left sinus.
yeah,
What about
which
the left
sinus is
sinus?
that? Yeah, which sinus is that? Left
Left maxillary
sinus.
sinus.
Yes, thickness. So there's a polyp here in the left
Oh,
maxillary sinus.
okay.
Okay,
More and
so
more
you
people
see this one is
answering.
quite clear. So this is quite clear, but you can see the thickening over here. Okay, in this case, very interesting. Other than the maxillary sinus, I'm trying to show other findings in this patient.
Does the patient have
What's that?
you know, Graves' disease with the eye that's huge?
Oh, no, the one exophthalmos, no.
That was
No.
okay. What other things are you showing?
Yeah,
Anyone other than the left sinus?
yeah.
Left lesion under floor of
Left orbit. This
lesion.
one, no, this is just a bony outgrowth only, not this one. Are you talking about this?
No, I need to mute people. Okay, which one are you talking about?
Lesion under floor of left orbit. Are you talking about this?
Okay, are you talking about that, Margaret?
Or this one?
Yes,
This polyp?
yes. Yeah, I was talking about that. The polyp I saw earlier, then you asked what
So you're
else.
talking about,
Okay, what else?
so these are just bony outgrowth, not
Okay.
significant. So the
Okay.
thing I want to show is, you see the turbinates, these are inferior turbinates, right? It's supposed to pointing outward both sides. Okay, but in this case, this patient, she has a paradoxical middle turbinate. This is the middle turbinate. You see it's facing inside, medially. Okay, so this is abnormal.
Why is it abnormal? What is the abnormality?
This one facing in is, we call paradoxical middle turbinate.
Okay, but
This is
is
okay, this is another patient. This is a normal one. You see the middle turbinate is facing out, like same direction with the inferior turbinate. Can you see?
is it born like that or is it a
It's
disease?
born like that. It's
Oh,
born
I
like
see.
that. So you
Okay.
see, this is the facing outward here also, and then the middle also follow. But in that case just now, is facing inside. All
Oh,
right,
I
it's a
see.
very interesting case.
Interesting to you.
Interesting. So another thing in this
It's
patient,
possible for us to be that.
oh, interesting, yeah, is it? This very nice picture.
Yeah,
And
very
then
nice. Okay.
in this case, there is this one concha bullosa. meaning there's a airfield space at the middle turbinate here. Okay, so this is a normal variant in CTPNS that we actually quite commonly can encounter this kind of findings. Okay,
Okay.
so we're going next. Okay, what about this case? Middle-aged 55 years old man coming with leg swelling and pain for 5 days.
Osteomyelitis.
Differential diagnosis. Some more?
Lytic lesion.
5 days. One more clinical features. No,
Jai
no
said
fever.
gouty
Yes,
arthritis.
gouty arthritis, correct. Halim also said gouty arthritis is correct. Can you describe more on this X-ray why you say gouty arthritis?
Okay, so give us the description instead of just
Yeah.
giving, okay, red bite lesion.
Red bite region, so erosion here, and then one more thing.
Red bite lesion.
Hanging sign,
Hanging
yes,
sign.
hanging.
Wow,
The
Halim is good, huh?
yeah, your radiology in
Really,
radiology field.
even this Chiayi also not bad. Oh,
Yeah. So another thing, other than this bony lesion here, there's trophy at the soft tissue at this
oh
region.
yes.
Okay, soft tissue swelling. So this is a gouty arthritis X-ray. Okay, next.
Okay, wait, before you go on to the next, our session, our Zoom is going to be filled up soon, 90 over people a day. So if you are a nurse, I would appreciate if you would let the doctors enter because we're not giving e-cert today because somehow or other Zoom cannot be streamed live to Facebook. So we will just concentrate on Zoom and Docwitty. Okay, let's go.
Okay, what about this X-ray? Elbow alleged fall.
A large fall.
Hmm.
I'm not good at this at all. My eyes.
I'm trying to
Okay,
answer.
anyone? Radial head fracture.
Okay, some more. Good.
Anyone
That's
else?
the correct one. Some more. Fracture only is not enough for this X-ray. Ulnar, no ulnar fracture. On radial head fracture is correct. Plus, actually, there's dislocation already or subluxation of the radial head over the elbow joint.
Well, this is very good for radiology
Yeah.
student.
So
Okay.
ulnar, there's no fracture in the ulnar. It's only the radial head. Okay.
Can you show me the fracture, please? I'm so sorry.
Over here, you see the line here, some cortical discontinuity.
Oh, so not.
Radial head fracture is very difficult to see actually. Olecranon, no, in this case, only radial head fracture.
Wow, Jai.
Dislocation, good. She can answer. So this is the CT scan for the same patient that you can see the fracture line is actually this small, and then some cortical discontinuity over this region, and the orientation of the radius is already out from the shoulder, elbow joint. Okay. So from this X-ray itself, you can see fracture at the radial head is very good. Okay. So
Okay.
this case, this is an easy one.
Okay. Okay, what is this? Shoulders dislocation.
Okay, some
so
more.
left shoulder dislocation. Surgical neck of humerus fracture. Oh, that's
Yes. Can you
true.
see the fracture, Betty?
Yes, can see now after it was
Yeah.
mentioned. I
Yes.
can see the dislocation. I was
Mm.
quite happy with that.
Yeah, but there's fracture, so
Yeah, that's right.
don't miss a fracture in the shoulder. Okay, this is very
Why
easy.
surgical neck? What does
Over here.
surgical neck means?
Surgical neck is here. Okay, let's try explain. Anatomical neck is over here, and then surgical neck is some
Oh, I
anatomical.
see. It's a okay. So it is surgical neck is actually a description of
Description for the anatomy part. I think some management, not sure, will be different with otology. Next time must ask Dr. Putra.
Oh, I
Yeah.
see. Whether the management is different
Mm.
for the
Yeah, based
surgical
on the
neck.
line location.
Okay,
Yeah, but you can see fracture that's good enough. Okay.
okay.
Then the next, let's the
I can't hear you.
okay.
Okay,
This case.
okay, this case.
So there's pedicle screw for the previous discectomy and surgery of the lumbar spine. That's okay. So the pathology I want to show here is not about the spine.
Anyone? Most like appearance of
It's of
the
the
right
right
femur.
femur. No,
Why
that's
only
just
femur then?
because
Lytic
it's a
lesion.
not little lesion. This patient is quite old already. Sometimes you see the overlapping, there's a lot of tissue here, and then you see all the this one external artifacts. Sometimes we can show improper like shadowing of the bone density. No,
Fracture hip.
which
Asmahani.
hip? Where is the which hip? Which side? Where is the fracture line you see?
Must always describe right or left, yeah? Very important in radiology. That much I know.
Yes, you're
Okay.
right.
Fracture hip. Asma, which left hip, left hip. Asma
Meaning
said right hip.
where?
Timothy said left. So Jia Ji said left hip definitely not fractured. So Asma said right hip. Right hip. Oh, Lee Ziyong said left hip, the discontinuity of
Yeah, left
chanting
hip.
line.
But then when describing the X-ray, then we should know which bone that are fractured you are talking about.
So
Hip
Halim said
meaning
consolidation. I words also I cannot get.
oh yeah, left neck of femur fracture. Jiaqi, I saw your answer just now is correct. So can
Oh, I
this is
see.
fracture line here. Ah.
Yes.
So this is a quite chronic one because you can see the sclerosis and callus formation here. Sorry, this part.
Yes.
So there's fracture here, left neck of femur fracture. So while looking at the pelvis X-ray, always follow all the line draw to make sure are all continuous. Okay, then you will see the line here. And also must always draw the pelvis bone and all. Make sure there's no fracture. So this is a Shenton line. Actually,
Where's the Shenton line?
this is a Shenton line. Following the medial border of the femoral, follow here and then going to the inferior
Oh, I see.
margin of the
Okay.
superior pubic ramus. This is a Shenton line. Okay, so there's left neck of
Okay, you're breaking up. Is it mine or yours?
12 years old boy coming with right hip pain.
Oh. Okay, this one I don't know. What is
What
SCFE?
is SFFE?
What is that now? Everybody is saying SCFE.
Yeah, we
What's
know,
that?
but then the rest who are not in radiology, they won't know what is SUFI. What is SUFI?
Okay, please explain.
SCFE.
Everybody knows except me.
Yeah,
Sleep
they know quite
capitis
well.
femoral okay, even after they have explained in full, I still don't know.
Sleep capitis for apophysis is sleep little bit, but what is the main point I want to show here other than this SUFI? What happened with the epiphysis?
Irregular?
Some more?
Oh,
Always compare the right side and the left side. Then we can have
so the
better
right side is
description.
the one that is more
Painful and
displaced,
abnormal. But this is
avascular
this is
necrosis.
correct.
Huh?
Yes, avascular necrosis. Timothy, you are right. AVN, Ong Chuan Ming, you are right. Okay, so you can see there's a flattening. Can you see the flattening
Oh,
of
yes,
the
yes, yes.
devices compared to this one is smooth dome and also sclerosis here. So this is AVN. Okay, can be due to underlying untreated DTH when this boy are kids younger time. So this left with the Perthes disease here. Okay, at the end
But
of
this
the,
disease is the same as avascular necrosis?
yes, is another name, avascular necrosis of the femoral epiphysis.
Or is it the
Mm.
same if let's say an adult get avascular?
No, we only use this word in adolescent case.
Okay.
Mm.
And this is because of what's the reason behind it?
Maybe underlying DDH untreated or SUFI, many underlying cause can cause this.
Oh, I
Mm.
see.
Okay, any cause that can cause avascular necrosis. So remember the description for avascular necrosis is only flattening and then sclerosis, deform, then normally will point to avascular necrosis.
Description is extremely important, guys.
Yeah,
Not just the diagnosis, yeah, especially when you are doing your exams.
yes. Okay, what about this? Low back pain.
No back pain or lower back pain?
Low back pain.
Oh,
Not
low back pain. Okay.
Mm.
Low back pain.
Or back pain, always have back pain. 60 years old, female, back pain, chronically. So there's spondylolisthesis L5S1. Okay.
Compression fracture of L1 with degenerative.
Chachi is very good. She can answer all my film.
Is it a guy or a girl? Chi.
Chachi. Yes, spondylolisthesis, okay, correct. Plus spondylosis, degenerative changes, and there's this one, L1 compression fracture. Good, that you can find. Can you see,
Wait,
Betty?
hold on. Let me see. So the
Mm.
compression fracture at L1, okay, I can now, okay. And then the spondylitis L5S1, is there one?
1, 2,
No.
3, 4, 5, S1. This one, I think this is the lumbarization of the sacrum. So you can see it's on its own, but count from here is this one L1. Okay, so roughly there. So you can see the vertebral height is narrow and with wedge-shaped appearance.
Oh,
Okay,
okay.
so this is a compression fracture. It can happen in any other level. Okay.
Very good. Are you a girl or a woman? A
You
girl,
can answer here.
a guy. Yeah, he's a guy.
All
I
right,
am
what
so
about this?
disappointed. I thought it was, that's why
Oh,
you're,
guy, Jachi is a guy. Thought it's a girl, right?
I thought it's so smart, sure must be a girl. Okay, go on. Okay,
This one,
this one.
15 years old boy.
Somebody, okay.
What is
Hydristic hair on end appearance.
correct, hair on end. So what is the most common cause for hair on end?
Who say leukemia? Thalassemia.
Thalassemia, most common cause, thalassemia. Multiple myeloma, we won't show hair on end for multiple myeloma. It's major thalassemia.
Oh, I see.
Can you see the hair on end?
Oh, yeah. I mean, I can see it's that one. But I never knew thalassemia will cause this.
Yeah, this due to thickening of the trabeculae of the skull diploid space.
Oh, this very interesting picture.
It's really show like that one.
Oh, okay, good.
Mm.
Very interesting indeed.
This one, spot diagnosis for exam case. Sickle cell anemia also can have this appearance.
Okay, and then the description is really hair on end, huh?
Hair on end, yes, hair on end.
So where does it end, the bone?
This one is all due to the appearance of the medullary erythropoiesis or
Okay.
hyperplasia in thalassemia, then they can cause this hair on end appearance on X-ray. But I don't have the picture for thalassemia of the hematopoiesis image of the spine. Next time I will show that. Okay.
Okay. Don't tell
Okay.
us the answer yet. Maybe we can know. Okay,
Yeah.
go on.
All right. So next case. Okay. 2 years old coming with cough and low-grade fever for 5 days. Yes. You see, Betty, your student all are very clever. They can answer immediately.
Yeah, I know. I told you it just need 3 or 4 slides, and then after that we can't stop them.
Good. This is a viral crow. So what is the
Viral,
virus? Yes.
And what's the sign? What sign is it?
Yeah, they answer already.
I
It's
know, but tell me lah. I don't know where to look.
steeple sign. Steeple sign.
Yeah, I
So
know,
you
but
can see there's this is a trachea, right? Then this is a narrowing. You can see
I
an
see.
inverted V sign here. Okay? It's due to the laryngotracheobronchitis and then narrowing of this glottis here. Okay? Yeah,
Wow.
parainfluenza virus, RSV, yes, these are the 2 common viruses that can cause viral croup, correct? Steeple sign, inverted V, okay?
So they will get stridor lah.
Upper croup, barking cough.
Okay.
Stridor upper,
Yeah.
not really. What is trichomalacia? Stridor normally
No,
trichomalacia.
it's not the, oh my God, I want to say also I can't. Pertussis.
The pertussis won't show this X-ray, it's different.
Oh, I see, but they will have whooping cough. Whooping cough is
Whooping cough is different also, right? I think whooping cough, I think it's different also.
diphtheria. Oh my God.
Diphtheria is different. Diphtheria is pertussis.
Okay,
Yeah.
never mind.
Don't confuse the ground.
Oh my God. Okay,
Let's go for the next
I've
X-ray.
given back my pediatric also. Okay, whooping cough is pertussis, so
correct.
I'm correct.
Yeah.
Okay, thank you.
All right. Okay, what about this?
Okay, go on.
This is a left foot pain.
Yeah, give them some time. Anyone? Suddenly so quiet one. This must be very difficult.
It's easy.
Chia, chia, chia,
For you, actually, Emily,
Chia. Okay,
normal X-ray. No, not normal. I won't show normal.
I can see a sesamoid bone.
All right.
Somebody also says
Good.
sesamoid.
You can see sesamoid bone is correct. Some other thing. So for X-ray, always draw the line one by one. Okay. Then look at the appearance. Anything different from the rest of the bone. If you see at one glance, normally sometimes we hard to detect abnormality, but when we see one by one, then we can see the abnormality. I can only guess it's somewhat, no. So, okay, I give some hints. The hints at the metatarsal head. So I guess everyone know where is the metatarsal bone, right?
Okay. I shall not.
Metatarsal bone, right? You should know, right?
Second toe.
Yeah, second metatarsal. So what is the abnormality there?
Oh, second metatarsal.
So from here, this is the big toe. First, second, third, fourth, fifth. So you're guessing at the second is correct. So what is the abnormality in this X-ray?
Oh, come on, guys.
Difficult, this one. Difficult.
Must be lah. They're very smart, what?
All right, correct. So this one, okay, let's
Don't know how to explain.
Okay, so the problem here is no fracture. So there's no cortical discontinuity. But look at the metatarsal head here. So arthritis, no. So you can see this one again. From this one, you see the dome is very smooth and rounded, right?
Oh, yeah.
Okay.
Yes.
From this one, the second one, that's flattening again. Okay.
Okay.
And then you see the bone density here is like a slightly blackish, right? Like grayish. But this one you see increased density. So meaning there is sclerosis. Okay. So with flattening and sclerosis, point to.
Osteoarthritis.
No, we just talked about that.
Oh, avascular necrosis.
Yes, correct. So
Oh my God, I got it. I was going to say avascular necrosis, but I never heard of avascular necrosis of a metatarsal.
Oh, it's called Freiberg disease. It's also a case of spot diagnosis in radiology examination.
Oh my God, I got it, guys.
Yeah, you're doing so well now. Okay, avascular necrosis. So it's again flattening and sclerosis. So when you have a glance there, you can't really differentiate, but you look at it one by one, then you can see, right? You can see the difference.
Okay, now I will never miss an avascular necrosis.
Okay, sclerosis and flattening. All right, so next, let's go to the next one. Okay, what about this?
Okay, there's no flattening.
Marathon runner with the right foot pain.
Marathon runner with a right foot
Mm,
pain.
Chronic right foot pain for 3 months.
Must be a hairline fracture somewhere. I think it's the last one. The
Some guys
metatarsal.
give me some answer. It's
Okay,
also an interest.
Marshall
Martial fracture.
fracture.
What is
Where?
martial fracture? What is a martial
I
fracture?
don't know. I don't know.
I also don't know.
Second
metatarsal.
metatarsal. Chia Ji said. Chia
Yeah,
Ji.
again, metatarsal, correct. Martial fracture, another name. March fracture, March, not
The-
martial.
There's a bone reformation.
March, same lah.
March, yeah. March.
March fracture.
Second.
March. Yes, second metatarsal. So what is the Yes, stress fracture. Fatin got it right.
Yeah. Okay. Please show it to me.
So
Okay.
again, draw following all the bony outline. Metatarsal. You see this part?
Uh-huh.
This is the periosteal reaction here.
Oh,
So
I see.
that this, can you see now?
I can see that. Yes.
So these are findings of a stress fracture of the metatarsal bone.
Oh, but there is no fracture line per se.
It's chronic already, so you can see periosteal. You won't see a line. Normally, you will just see a periosteal reaction. It can happen in any of the metatarsal bone. So it's stress fracture of the metatarsal bone. They still need to rest the foot. Okay?
Okay.
All right. Yeah, good.
Good.
Next. What about this?
Okay, this one is the same.
Yes, this is the same, but
It's
happen
the
at
fourth one.
the metatarsal. Okay?
Oh.
So now we can see the findings with periosteal reaction is a stress fracture.
Periosteal reaction.
Okay, what about this? This is an easy one. Easy peasy.
Easy peasy. OA. Knee OA.
Correct. Yes, this is a knee OA.
Bilateral knee. Okay,
Bilateral.
bilateral. Grade 4 bilateral knee
Grade 4
OA.
some more. Good. So as usual, subchondral sclerosis and then osteophyte narrowing of the medial joint space. This one is severe with impacted joint space already. Okay, this is an OA of the knee, the severe one. Okay, come. What about this? Today we can go very fast.
Today got a lot of people who knows. And these people are hardly, I never seen them before, I think. Have you all joined my session before? I only know Gopi. Distal end radius fracture.
Yes, good. There's fracture here. Can you see?
Oh yes, now I can see.
So there's fracture line. Distal end radius fracture. Very good. So we're going to the next. So what is the name for this fracture?
Colles fracture.
Colles. So fall inner outstretch. It's not Smith, Halim. It's a Colles fracture.
Oh my God, I
Why?
got it right.
Now, why do you say Colles fracture?
Because I can only remember Colles fracture.
Okay, volar displacement. No, dorsal displacement. Normally, we'll use the distal fragment dorsal displacement is Colles fracture. So dorsal, this part, the distal part here going towards the dorsal direction, this is a Colles fracture, fall in an outstretched hand. Okay?
Yeah. Colles
Colles,
fracture is the most common.
dorsal displacement. Okay. It's more common, correct also. What about this? This one, you see the direction is different. So what fracture name is this?
Okay.
This, yes, this is Smith fracture, opposite of Colles fracture.
Mm.
Okay, so other than the Smith fracture, what else is fracture?
What else is fractured? What else is radius?
Yes, the radius styloid is also fractured. You can see this bony fragment stand on its own. Well, in this case, you see the styloid process is connecting with this ulna, but this one is coming out already. Okay, so there are two fractures here.
Wow, this one really okay.
Okay, again, Colles dorsal displacement going backward, and then Smith fracture ventral or volar. Okay,
Great.
so next, name of this fracture. I think everyone can see the fracture line.
Yeah, that one I can see.
Name of this fracture. Pediatric case.
Oh, this one.
Green stick. Yes, this is a green stick fracture.
Oh, green stick. Is it abuse?
Not abuse.
Oh, not abuse.
Not abuse. Fracture can because of fall.
Oh, I see.
Normally, when X-ray in abuse case, they will show multiple different area of callus formation.
Oh, I see. Okay.
Because they always have fracture and healing, fracture healing, then only
Yeah.
they will come to hospital.
I see. Okay,
All right, so this is a green stick fracture. Good. What about this? Betty, can you see any abnormality?
Stress.
Yes.
You asked me specifically.
Yeah.
Uh,
Pediatric hand.
okay, I'm going to do like what you
Mm,
do. Going around.
Taurus. Jashi is very good.
Stress radial
Oh,
fracture.
not stress. This fall. This is presented with fall. Where is the Taurus fracture? Can you tell me?
Okay.
Distal and
Distal and
radial.
radius.
Yeah, sorry. Yes. Can you see the bulkiness here? Just a
Oh,
small.
I saw it. But I
So
just don't know whether
it's
it's normal or not because you said
not
pediatric.
normal. So you see all the outline here is smooth, but then in this part it's just a slightly bulkiness here. Okay, so this is a Taurus fracture.
Also
Good.
due to fall.
So in pediatric case, there are a few types of fractures that can have different name. Okay. Next, what about this? Right knee pain on and off for 1 month.
Spur.
No.
Okay. Oh.
If anyone can tell me where is the abnormality first, follow the anatomy of this femur, tibia, and also the fibula. Anyone can see some maybe discontinuity, maybe lesion, or any changes? Anyone? Nobody? Tibia eminence fracture, good guess, but it's wrong. It's not in this case. So I give you more hints. The abnormality is at the femur. So this is the femur bone.
Okay, I saw it, but I don't know how to describe or what it is.
In lateral or medial?
At the right there, right is medial.
This is lateral.
Or lateral.
Lateral. No, it's at the medial side. Medial femoral condyle region. The abnormality is at the medial part of femoral condyle region.
I cannot.
Some, please look carefully. Try
Okay.
to follow the bony outline.
Fracture.
No fracture. Okay. Normally we don't call it fracture. Can you see there's this bony lesion here?
Oh.
This is an osteochondral lesion. Osteochondral lesion. can cause pain.
Oh,
Okay. So you can see a bony density here with the lucency surrounding it. This can cause pain. That's why we always do X-ray for this. Okay. Then they can be stable or non-stable, and it need to be assessed by MRI.
it moves us. Is it osteochondroma?
No, it's osteochondral lesion. We call it osteochondral. It's not
Is
osteochondral.
it lesion as in, is it a
You
growth?
mean, pardon?
Is it a growth?
It's not a growth. It's the displacement of the osteochondral bone here.
Oh, I
Mm.
see.
Okay. So
Okay.
next, this one easy. Everyone I think can answer. Heel pain.
Spur.
Yes, calcaneus spur. Okay. Can see?
Well,
It's
the spur is so really, there's a spur.
yeah, can really cause very painful.
Yes, of course, it looks like very sharp.
Yeah. So in this case also, patient come for MRI, then you can see the spur here with this one is post contrast, see some enhancement with the thickening, so can cause leading to plantar fasciitis also. Is one of the concomitant factor. Okay, so spur sometimes can be complicated case. All right. So next, okay, what about this?
Wow, today a lot of bony x-rays. Huh?
Today majority MSK.
Oh, MSK means musculoskeletal.
Musculoskeletal bony X-ray.
Oh, we haven't touched that, you know.
Hmm.
Okay. Anyone? I can't even remember the bones, I tell you.
Can't even, okay, just answer me, what's the name of the bone or which part of this X-ray is it?
Okay, anyone name me the bones?
Or which part of our body? Ankle, correct?
Oh, I see.
It's
Okay.
the ankle X-ray,
Tibia and fibula.
Fibula,
Oh,
no, it's normal. Just a view issue. So anyone, this is a bit difficult. Okay, so follow the bony outline again. So this is a fibula, normal. Distal tibia, we follow the outline, okay, no lesion, right? No discontinuity, so this is okay. So this bone is talus. So when showing the ankle X-ray, look at the talus properly, then you will see this lucency here. Can you see?
okay.
Compared to this part, there's some this lucency here. This also one of the osteochondral lesion of the talus.
Oh, I see.
So they have different appearance.
Just now was more.
More sclerotic. Just now the
Yes.
one is more sclerotic.
Yes.
You can see this outline, but on the talus, they can show as this focal lucency here. Can be due to trauma or repeated micro trauma also. Okay, can cause pain. Okay, next, these are easy.
Easy, guys. Come on.
Come on, this one easy.
The
Everyone can.
faster you answer, the more we go through. Clavicle fracture.
No, no clavicle fracture. It's
Dislocated
dislocated.
shoulder.
Yes, Jachi got it number one. Anterior dislocation. Okay, so
Clavicle
you can
fracture, no.
see the
Dislocated shoulder.
humeral head is displaced anteriorly and inferiorly. Okay, anterior shoulder dislocation.
Super.
Everyone must get it right for this case. Okay,
Anterior. Okay, so how do you know it's anterior? Why the anterior is so important?
even you need to be diagnosed so that you can do the CMR.
Okay.
So it's more common is anterior dislocation. Okay, much more common than the posterior dislocation. So anterior shoulder. Okay, what about this? This is a scapula wide view. So where is the humerus? Yes, this is
Oh,
posterior dislocation.
okay.
Very good. Why you say yes, light bulb appearance, though this is a light bulb appearance.
Oh, compared to just now?
Compared to just now, there's no light bulb. This is showing
Oh,
with the different position of the humeral head over the glenoid, so it's anterior dislocation and displays anterior and inferiorly. So this one is showing at the scapular wide view, and then this light bulb sign, posterior dislocation. Okay. So the common cause for this one is the fit or seizure.
oh, I see.
Electrocution also can cause posterior dislocation. That's why this one is much rarer than the anterior dislocation. Okay, come, let's go for the next case. This is the easy one. Give me description.
Some calcification. No, okay.
Some calcification. So sclerosis. So we always use the term sclerosis when you see
Oh, darker.
density whiter, more dense, use sclerosis. Okay. There's a
Sclerosis.
arrow here also. Yes, it's osteosarcoma. Copy is very good. Okay.
Hmm.
Periosteal reaction over here. You see the triangle.
Okay.
And then this fluffy sclerosis, abnormal sclerosis. Okay, this is osteosarcoma. Okay.
But the soft tissue got nothing, huh? Not much.
Tissue they will have a I mean opacity or swelling, but it won't show much on X-ray. This mainly to show the bone. So with this X-ray, need to proceed for MRI. Okay, osteosarcoma. Okay, what about this? Similar case. This is also osteosarcoma. Sunburst, yes, sunburst periosteal reaction. Then high density of the sclerosis. This also osteosarcoma.
Wow, this one
This one very scary, very painful.
very painful. Huh?
Very painful. Painful and swelling. They will present with a pain and swelling. Okay. So what about this? This one is a little bit hidden, but I think if you can see properly, then you can find the abnormality. So we are going towards the bone lesion, no more fracture.
Okay. Please try again to register because just now I actually locked it. Now I unlocked it. Okay, this one multiple lytic lesion.
Actually, only one, you will see one lytic lesion. Osteomyelitis is one of the differential diagnosis. Good.
Uh,
In this case, you will see this periosteal reaction here, linear periosteal reaction, and you will see the permeative lucency changes within the bony medulla. Okay, so this is a adolescent, 17 years old. So the diagnosis is Ewing sarcoma.
Ewing sarcoma.
Ewing sarcoma can look like this. Okay.
Okay, wait, this the picture on the left. The left is normal, is it?
No, these are the same picture,
Oh, okay.
different view. So we'll see the
Oh,
lucency.
different views.
Compare the density over this part, middle, which is normal, and then with this one, you will see the lucency. Okay, but in this case, there's no fracture yet. So osteomyelitis and malignant bone lesion are always differential diagnosis. They always come together. Okay, so this one.
Okay, this one there is also a lytic lesion.
Lytic bone lesion. So you will
Bone
see this is
lesion.
also a pediatric case.
So this is also Ewing sarcoma.
This also. So you have to give differential for Ewing sarcoma. Okay.
Good at this.
Also is the differential diagnosis. So it's based on the clinical ground. How is the patient presented with? Okay. Always differential diagnosis. So don't forget about bony malignancy. when pediatric or adolescent cases come into the clinic presented with pain and swelling, must always rule out malignancy, because I've met one patient about 15 years old, presented few times with pain and swelling, but no one did x-ray.
Okay.
No one ever did x-ray. So when she came finally to one of the doctor that did x-ray, then it already showed a very huge osteosarcoma. It's a very sad case. Okay. So next, what about this? Okay, this is a adult patient, 40 years old, with a hip pain.
This is secondaries.
Secondary scan is a differential, so you can now see there's a
Lytic.
lytic or loosened lesion in the, this is the greater trochanter of the left femur. Okay, so you can see a lytic lesion is good enough. Then you will give differential diagnosis for the lytic lesion. Malignancy, infection, or either lymphoma and all also can. Okay. So what about
Okay.
this?
Last two slides. Okay,
Mm.
come on, guys.
This one is an easy one.
Link for nurses. Sorry, today we're not giving any link for nurses because we are not showing on Facebook. So I mentioned it earlier already that we are not giving e-cert to the nurses. Yeah, sorry.
Scoliosis, yeah, correct. There's scoliosis some more.
I think there is this
Yes, spondylolisthesis, correct. So here they have some few level of, this one is retrolistesis going backward. This one also, and then L45 is the anterolisthesis. Okay. PID, normally we don't use the word PID for X-ray because I don't see the disc. So I will just say spondylosis or degenerative changes. PID need to be diagnosed on MRI. So other than that, can anyone see this linear calcific foci here? So what is this for? Susuk. No, this is not susuk. Susuk will be a thin, long line. Thin, long
it's not,
dash.
susut is real when you will actually see needles.
Yeah, but this is too short for susuk. Susuk will be longer.
Oh,
So what
susut
is this?
also happen in the stomach.
Susuk can happen anywhere.
Huh?
Yes,
Wow.
I've seen susuk in all part of the body.
But it actually works, susut.
I think it's work because the patient
Cause
come with susuk,
fibrosis.
right?
It will cause
They will,
fibrosis.
I don't know why they look prettier.
No, I think it's the same as
Like the lifting all and all, is it
yes,
threading
yes.
those clip? Yes, surgical clip. So what is this for? Previous of
Prevents
lap
poly.
cholecystectomy. So this Jiachi is clever. Okay, it's correct. So this is a cholecystectomy clip. Yeah. All right.
Okay,
So
last one.
one more. Okay, this one easy. Last one, easy one.
Fracture clavicle, right clavicle.
Yes,
I'm
there's
cleverer
fracture.
than Jiaji because he never said
Yeah,
it.
big clavicle fracture, correct. So everyone can got it right, huh? So
Yes.
now we all see X-ray, follow the bony outline, draw, then we can see where is the abnormality. Okay, so that's all
Okay.
for today. So let's continue for the rest of the cases next year.
Next year. Everybody, Happy New Year, Merry Christmas. Thank you very much for joining us. I am so happy that you participated. Do join us next year. I'm definitely going to invite Dr. Hamanchin back again. She's
I
my
need to
colleague in
find more
teaching.
interesting case for you guys.
Yeah, she's so excited. She loves it. Actually,
Yeah.
everybody who gives talk to me loves it, you know. They
Yes.
enjoy themselves very much. And next year we're going to have Beating Heart's first physical meeting, collaborating with Sunway and also Doquity, maybe in July. So hopefully you all can come. And then we will see what and I'm trying to launch a new webinar website. Okay, see how it goes. And see you guys next year. I won't be having webinar anymore for this year. I'm leaving for Nepal next Thursday, and then I'll be away for 2 weeks. So I see you back in January. Bye, guys.
Bye.
Merry Christmas. Happy New Year. Bye, guys.
Yeah.